Thank you very much, Chair. I'm going to try and cover a range of issues in the time I have this morning. I'll see how we go. I want to come back to disability vaccination in a moment. But first, I guess in breaking news, that it's been revealed this morning that there were 149 missing cases from Victoria's daily case tally yesterday. And instead of being 705, it should have been 845. Which would mean that it was the first time that in raw numbers Victoria has passed New South Wales in the current outbreak for the largest number of cases. And of course, Victoria had already passed New South Wales in per capita terms on Saturday, given the smaller population. To either Professor Murphy or Professor Kelly, I guess that puts the final nail in the coffin of that zero COVID ideology, that if you lock down hard and fast and early, that you can somehow control a Delta outbreak. Victoria couldn't have locked down any harder or any earlier in this outbreak, and yet here we are with more cases than New South Wales.
Professor Kelly, would you like to answer that?
Thank you, Secretary. Thank you for your question, Senator. Professor Paul Kelly, Chief Medical Officer for the Department of Health. We are, as you've pointed out, Senator, in a situation of ongoing local transmission of the virus of this new Delta variant in New South Wales and Victoria and ACT at the moment. Those three jurisdictions have had quite different approaches, as you've pointed out, in terms of the hardness and fastness of lockdowns. In the end, they've generally ended up in the same sort of place in terms of quite harsh lockdowns. Cases are continuing to rise in Victoria. They are, I believe, on a downward trajectory in New South Wales and have been pretty flat in the ACT all throughout that period. We are seeing that this Delta variant is much more transmissible in the community. We're seeing quite a different outbreak in two very key ways from last year's experience, particularly in Victoria. The first of those is that we're seeing more cases in children, and the second is that we are seeing far less deaths than we did last year. The main reason for both of those is, in fact, the vaccine rollout, which has been extraordinarily successful in decreasing death rates, in particular in those most vulnerable people. And Dr. Murphy's already mentioned those, particularly in aged care. That has been a spectacularly successful operation. I'm sure General Fruin will talk further about that later. So we are still seeing those cases. It is extremely difficult to control this virus. It's a combination, and will continue to be a combination even as we go higher in the vaccination rollout with test, trace and isolate and quarantine procedures that we've honed over the last 12 months, and public health and social measures. The need for those very strict lockdowns, however, will decrease, and they will decrease very soon.
Yeah, and I guess looking at those New South Wales figures and the case numbers appearing to be on a downward trajectory now, that's very encouraging for Victorians, because hopefully that's around the corner for us, because New South Wales obviously has a higher rate of vaccination than Victoria, but also much less strict restrictions than Victoria has right now comparatively, and their cases are going down while ours are still going up. How has New South Wales tracked against your expectations for cases based on that increasing vaccination rate?
So the committee will recall some when we're in General Fruin may wish to talk through some of the events of the past couple of months in terms of extra vaccines arriving from overseas, and there was a decision. It was my advice to the program and to the Prime Minister about pushing some of those first tranche of the vaccines we received from Poland into those high risk, high areas of transmission, areas of southwest and western Sydney, and that has absolutely borne fruit. That decision has been very much vindicated. We've seen through these past month or 6 weeks a quite rapid decrease in the cases in some of the most hard affected LGAs in southwest and western Sydney, and that I'm absolutely certain is due to the decision made to put vaccine in there, and specifically to address the issue of transmission in young adults. So that was the next phase of the rollout of the vaccine. That is absolutely allowed, as we've seen from the modelling that we've had, as well as other modelers have suggested, that as vaccine rates go up, you can start to titrate some of those public health and social measures, such as strict lockdowns, and get the same effect. In fact, the report we get every week and is publicly available from in terms of transmission potential and are effective, is now starting to show for the first time over the last month or so the true effect of the vaccination rollout, and that has by far been most felt in a positive way in New South Wales.
And the other component of that is, of course, ICU admission, which appears in New South Wales to be lower than some of the modelling indicated. I know the Burnet Institute, for example, was forecasting much higher rates of ICU admission in New South Wales. Is that a trend you expect to hold and be replicated across the country as those higher rates of vaccination are achieved in other states?
Yes, I do, Senator Paterson. That's certainly, we know from the beginning of the development of the vaccines, both the mRNA vaccines, of which we have now 2, and the AstraZeneca, that they have a very large and lasting effect on decreasing severity of illness. And so we know that the issues we're seeing in all 2 states and a territory that are having ongoing outbreaks, this is very much an epidemic of the unvaccinated, and that so cases themselves, admissions to hospital in particular, ICU rates and deaths are all lower in those that are vaccinated. I can illustrate that with some actual figures as up to and including yesterday, and I'll point out by age group. So again, just as we've said before, that older age group, so 70 to 79 years, there was 4% of the total cases were vaccinated. Only 3% of those that are in ICU are vaccinated. In the younger age groups, in the 16 to 69 age group, there was no one in intensive care that was fully vaccinated. And so these are really important elements to consider. Not only is the vaccine effective, at least in part, to stopping transmission between people, but most importantly, it does slow down and decrease those cases of severe illness. So I agree with what you've said there, Senator, that whilst the initial modelling for New South Wales, which was based on their trajectory of vaccination at the time, suggested that they would have a peak of ICU and hospitalisation admissions in late October. That rise has been halted, and it's in fact decreasing now. There is always a gap between cases and those severe illnesses, so we wouldn't count our chickens before they're completely hatched. But at the moment, it certainly looks very positive that the peak of both cases and severe illness has been reached in New South Wales. Now, they are starting to loosen some of the public health and social measures as they get to that 70% total vaccination rate. We'll just have to see what that shows, but of course we're monitoring that very closely.
Thank you. There was a report in The Australian today that said that Victoria will have a sufficient supply of mRNA vaccine doses for 100% of Victorians aged 12 and above to be vaccinated by the end of October, and then there will be 500,000 spare. First of all, can you confirm that reporting is accurate?
I'll get General Fruin to respond to that, but we are no longer supply constrained, General. Yeah.
So, Senator, we're just at a point in the program now where we believe we're shifting from what has been a supply-constrained model to a demand-constrained model. With the forecasts of mRNA vaccines, both Pfizer and Moderna, that we anticipate both through October and then into November, we think that no longer will it be the sort of supply-based rationing of mRNA vaccines that we've had to do up until now. It really will be about there being adequate distribution points, adequate mRNA vaccines, still AstraZeneca available, and really as we start to progress towards those 70% fully vaccinated, 80% fully vaccinated rates, it's all going to be about making sure people continue to come forward. If people do continue to come forward, then potentially, we can progress through 80% and beyond. But it really is now about public willingness to get vaccinated.
But just want to understand that those figures are right. 549,753 mRNA dose surplus if every Victorian aged 12 and over is vaccinated, and a surplus of a bit more than 1 million if only those 16 and over were to be considered. Is that accurate?
Look, I need to take those numbers on notice, Senator, to give a proper response here.
Okay, well, the purpose of my question is what I'm trying to understand is if that is the case, if we're now moving into an environment where we're no longer supply constrained, why do states like Victoria continue to persist with a 6-week dose gap for Pfizer rather than a 3-week dose gap as recommended by ATAGI?
Senator, I think that's a decision for the states to make. ATAGI has made a broad range of recommendations at minimum of 3 weeks, and they can go longer. So there's no particular reason. I think it's a programmatic decision for different states have made it in different contexts. So
I appreciate it's not your decision, Professor Murphy, but I'm just trying to understand it because it doesn't make a lot of sense to me to delay people being fully protected when they have the opportunity, and clearly now the supply is there. It seems like if there ever was a time when Victoria needed to ration and spread out the doses, that's clearly no longer the case.
It would appear on the supply projections we've got now that there should be sufficient to bring that forward, and I'm sure they're considering that at the moment. I don't know whether General Frewen wants to comment on these discussions with Victoria.
No, the various jurisdictions have applied different dosing parameters depending on where they are in both the rollout and where they are in terms of hotspots. There has been prioritisation of first doses. There has been both extensions and contractions within dosings across the jurisdictions progressively, and I think the states and territories are adjusting those as they go.
Because there's a great chart produced by the ABC, Casey Briggs from the ABC, that tracks the time between doses by state and territory, and it shows that Victoria has the largest gap between doses. I think 42 days was the latest, and some states have as low as 32 days. That's quite material in terms of when we're going to hit those 70 to 80% double dose targets and when we're going to be able to have a significant amount of freedoms returned to us. So it just seems inexplicable to me why Victoria is out on its own with such a large gap between its doses.
I'm sure they'll be reviewing their program with the new supply, but I think what the point that you're making is that supply is increasingly no longer a constraint in terms of programmatic decisions. So we have good supplies now.
Right. Well, that's very positive. Just finally from me, Chair, I just want to come back to this issue of people with disabilities and their rates of vaccination. How do the rates of vaccination of people with disabilities compare to the population at large?
General Frewen, would you like to answer that?
What was the question?
Disabilities, how do they compare?
Right. The disability residence rates, which I mentioned in my opening statement, Senator, presently for the residents in facilities are at 75.2% first dose and 66.7% fully vaccinated. And for the disability workers, these are registered workers, vetted workers, they're at 73.9% first dose and 59.3% fully vaccinated. And both of those fully vaccinated rates are ahead of the national average.
Great. Thank you very much. Thanks, Chair.